Good afternoon, and so my talk is going to be a little bit different. It's quite different actually from what you have heard so far. I was given the task to talk about heart failure treatments, and in the spirit of TRICO, where you not only learn evidence basis, but we are heavily focused on procedural skills and how to make things simple, as Sanjog elegantly demonstrated. I agree with him, there's no such thing as complex anything, it's just how you can simplify things. So I'll go over some of the common things you know, and then I'll show you a technique that actually Tejas invented. We were a part of it, and how we apply it to non-coronary distributions. The heart failure with reduced ejection fraction, as we all used to call systolic heart failure, is a very significant health problem, leading cause of hospitalization. It has a prognosis that's worse than many common cancers, which we hardly realize in the medical field. If somebody tells you somebody has lung cancer, you feel very bad for them. But if you tell somebody you have a 30% ejection fraction, they feel like, well, it'll get better. And it has a very complex pathophysiology, mostly neurohormonal changes driven by a mechanical insult. Because it's neurohormonal, majority of the treatment is actually medical. Many advances have been made. I'll go over those advances in a reverse order chronologically. The latest advance is the drug that addresses the natriuretic peptide system and the old renin-angiotensin system. The Paradigm heart failure or Paradigm HF trial, a very large study showed that a combination of neprilysin inhibition and ARB leads to a sizable reduction in a very hard endpoint of cardiovascular death and heart failure hospitalization. In America, it's marketed as Entresto, and I'm sure in India and the rest of the world there are many other brands. But this is a game changer. Not only leads to symptomatic improvement, but it leads to ejection fraction improvement and obviously survival. Before that, we had learned that beta blockers not only were not contraindicated in systolic heart failure, but became a cornerstone of management. They improve all-cause mortality in systolic dysfunction, as shown here in this composite slide showing many beta blockers: bisoprolol, metoprolol succinate, and carvedilol. So the guidelines recommend all these medications. Well, we are technicians by design, by training. So we really love our science and our chemistry, but eventually we want to do things to these patients to make them better. And one of the things that works in heart failure with reduced ejection fraction, especially in patients with asynchrony, is cardiac resynchronization therapy, or what we call biventricular pacing. I believe this procedure is meant for interventional cardiologists. Even though electrophysiologists do this, I think the IC community is well suited for this. The literature, as summarized in the guidelines, shows that anybody with a QRS duration greater than 150 milliseconds, if resynchronized, will improve outcomes. These are busy slides, but the bottom line is if you have a left bundle morphology QRS and a duration greater than 150 milliseconds, you can safely recommend cardiac resynchronization therapy with or without defibrillation, and you will lead to an improved outcome. Multiple randomized controlled trials have supported this class 1 and other recommendations you see here. So why are we talking about this here? Well, when you do CRT, you realize that it's much more difficult than a moderately complex coronary intervention. The anatomy, the tolerance to the equipment in the venous vasculature, and the sick patient substrate makes it very, very tenuous and frequently very difficult to treat these patients and deliver a successful procedure. So let me go through a few cases. Now, one of the basic rules of vascular or endovascular medicine that I have learned is that the other name of complexity is transitions and adversity created by large steps and razor effect like phenomenons. everywhere we struggle and we modify plaque and we do things to the vessel, it's because our hardware is plowing through adverse terrain. So these cases are all demonstrating that in the electrophysiology world or the CRT world, 62-year-old male with a very poor ejection fraction on full guideline-directed medical therapy, previous bypass, NYHA class 2 to 3, sinus rhythm with a left bundle branch block pattern with 160 millisecond QRS. And we go from the left subclavian, we implant a defibrillator with a lead in the atrium and the ventricle, in the right ventricle on the septal aspect. My left epicardial vein approach includes a 9 French sheath in the superior vena cava, as you can see right around here. And through that, we put a 5 French Amplatz diagnostic catheter, usually an AL2, because most of these patients have very deformed and large atria. And then we engage the ostium of the coronary sinus. And as you can see, we successfully did that. And this typically, once you learn it with a 5 or 6 case learning curve, takes less than a few seconds. It's not very difficult to do. The problem occurs when the next step comes in. Coronary sinus has a very bad habit of having anatomic deformations and disease in the wall of this large vein itself. So the next step in the procedure is to put your sheath in the coronary sinus, find an epicardial vein, and advance your lead in that epicardial vein to pace the left ventricle. Well, in order to advance a sheath, we push the sheath down, and in an ideal coronary sinus, it'll walk right into it. The sheath comes with a dilator like usual. And in this case, we came down to the ostium of the coronary sinus, and because of the complexity of the angles there, the sheath is not going in. So being a coronary operator, my next instinct was to put a buddy wire. So we put a second wire, advance the 9 French sheath, and no success. The sheath does not want to enter the coronary sinus. And we learned this learning radial access, that the mechanism of failure of advancing equipment is most of the time big transitions in your hardware. So a buddy wire 035 times 2 is 070, and a 9 French sheath is a 3 millimeter wide sheath. There is a very large transition there. That is what was plowing through the ostium of the coronary sinus. So what did we do? We put a 3 millimeter balloon at the tip of this 9 French sheath. And as you can see here, using this, what was described as balloon-assisted tracking more than 9 years ago now, this complex coronary sinus entry site is crossed. The sheath literally jumps in because the balloon slides across and eliminates the transition there. Once the sheath is in the coronary sinus, the rest becomes very simple. We advance the lead into the epicardial vein, and now we have a nice biventricular system. This is another case done by one of our electrophysiologists. Difficult coronary sinus engagement, an AL3 catheter with a hydrophilic wire, literally fishing around in a low EF patient with a bioprosthetic aortic valve. And as you can see, he's really struggling. Uses the EP catheter, gets in the coronary sinus and could not cross beyond the proximal aspect of the coronary sinus. So he had heard that we had some tricks up our sleeve. So he calls me from across the room from the cath lab, and we use our typical AL-based approach, get in the coronary sinus, and by no means would the CPS 9 French introducer sheath enter the mid-coronary sinus or further. So again, any resistance is usually caused by transitions, and a 3 millimeter balloon at the tip of the coronary sinus over an 035 wire here, and you can see how gracefully it enters without any glitches, etc. And again, after that, things are simple. All of these cases are involving balloon-assisted tracking, and I just want to show that the tricks that you learn here in a radial course or in a complex coronary intervention course come in handy not just in the coronaries, but in any procedure you do. We have literally used balloon-assisted tracking in placing 14 French sheets through a complex iliac in impeller placement in the middle of the night, etc. So another case here that you see, let me just go forward for the sake of time. And again, we enter the coronary sinus, look at the pushing of the coronary sinus with a telescoped system here. We have AL and a 9 French trying to go forward, buckling in the right atrium, a very dangerous maneuver. People have perforated and sheared off the coronary sinus and had a fatal bleeding in the cath lab when this happens. So instead of forcing it or using very traumatic equipment, use our balloon-assisted tracking. Simple technique, and by doing this, you can gracefully enter right into the coronary sinus or any other structure for that matter and complete your procedures. So the bottom line is, in any vascular medicine case, if you're having trouble with navigating, think of razor effect. Think of large transitions. We assume that putting a 035 or a 014 wire, everything else is basically we are entitled to have advancement and we should not be needing to do anything else. Well, that's far from true. And by eliminating transitions, and the balloon-assisted tracking gives you the most elegant way of doing it, you will succeed more than expected in any of these hurdles that you face. So procedural hurdles are not uncommon in so-called complex substrates. Understanding the mechanism of failure is very essential, and using your catheter skills and tricks and tips that you learn in courses like this will improve your procedural success no matter what your sector of work is. Thank you.